Today I'm going to talk about something that we don't necessarily talk about in urology very much. In fact, I don't really ever remember talking about it at all when I was a trainee. But it's something that was partly derived from an interest that I had, and we had some local expertise in Ottawa that had affiliations with blood services. And I'll talk a little bit about kind of how I started in Ottawa and some of the things that we looked at that have led to some of these trials and research that we've done. Now, of course, a lot of people put a lot of work, and I wanted to start off by just thanking or acknowledging. So Luc Lavallee was a fellow with us, and he's joined us as staff a couple of years ago. He did a lot of work in this area with me. Dean Ferguson is not a urologist. He's a methodologist who is sort of an expert in transfusion medicine. Chris and Ilias, a lot of you guys would know. Nahid actually was a student with me, then went to medical school, and is now a graduating urologist at Western. Ranjita has been my analyst for the last 7 years. Greg Knoll is actually a nephrologist, but a very accomplished researcher as well, who's helped me. Mark Spurl, you guys may recognize, he was a resident with us who did some of the preliminary work, and Kelsey was my research assistant for several years, and then eventually got into med school in Calgary, and is graduating from there this year as well. So a lot of people put a lot of the elbow grease into what I'm presenting on today, and none of it would be possible without them. So I want to start with a clinical case because I think that this is important to contextualize what we're talking about. So this would be a very common scenario that we would see. A 61-year-old woman who has BCG refractory high-grade urothelial carcinoma, has gone through salvage therapies with no success, is a smoker but otherwise healthy, laboratory is normal, scans don't show any metastases. So somebody like this generally would be treated with a radical cystectomy. And when you have that conversation about radical cystectomy in particular, I think it's important to have a conversation with the patient about what they can expect, specifically in terms of what their risks are. But there have been numerous studies that show that even clinical experts, like all of us in the room, are very poor at estimating what the risks are in our patients. Whether we remember the things that go bad or we don't remember the things that go bad, we're notoriously inaccurate in terms of estimating our own risks, even with something as common as radical cystectomy. So you can use, and I'm a big fan, we were talking yesterday about it, you can use some risk calculators. And now these are not perfect, far from it, but they do help. So you can put the procedure in here at the top. You can put all the patient demographics below, and this is derived from NSQIP. So there are about 3,000 or 4,000 cystectomies, maybe even more now, that generate these risks. And for most of these things, the incidence of some of these adverse events are actually relatively low, especially when we think of something as major as a radical cystectomy. So MI is fairly infrequent, pneumonia, UTI a little bit more, but usually not a significant complication. DVT, relatively low even in these patients, renal failure, return to the OR for one reason or another. So generally fairly low complication rates for this specific patient. But what about risk of blood transfusion? So if maybe I'll ask Peter, what do you think, or do you know what the risk of blood transfusion is among your radical cystectomies?
Mine personally or center?
Well, maybe your center. Probably your center would be better because, I mean, I'm guessing you may get potentially more complicated ones and things, so maybe for your center.
I think during the hospital stay, it's under 40%.
So,
That's male, female.
Male and female, yeah.
Male,
Right, yeah. So that's interesting. So we did a survey, actually. Nahid, who was a student at the time, surveyed, and these were all Canadian surgical oncologists. We had a very high response rate, thankfully. A lot of you guys filled in this survey. And almost half of respondents said 20% or less. And in fact, when I was looking at this area, I would have guessed probably 20%, 1 in 5 would get a blood transfusion. We had Mark Spurl look actually at our series. He had looked at sort of 300 or 400 radical cystectomies, and our risk was 52%. That's either during surgery or within 30 days after surgery. And really, as I will show, study after study is pretty consistent with what you guys found. Now, there are some risk factors. Females are higher transfusion risk. People with anemia, we're using more and more neoadjuvant chemotherapy, so It's not uncommon for our patients to be anemic when they present to us. If it's a salvage case, often they have a higher risk of blood transfusion. But none of these were so great that we could say, okay, here's the really high risk for transfusion, here's the really low risk. Everyone essentially was at risk. And if you look at published series, they range almost up to 100% really, but 30 to 70% is where most institutions have a transfusion rate, which is extremely high. And these are not centers, in rural interior British Columbia or Ontario. These are Vanderbilt, Memorial Sloan Kettering, MD Anderson, Mayo Clinic, USC. So these are centers of excellence, quote unquote excellence, that have these rates of transfusion. When we looked at NSQIP, this is something that Luke did a few years ago. We saw it consistent with what you guys found, about a 40% intraoperative transfusion and about a 10% postoperative transfusion within 30 days of surgery. So somewhere around 50% risk of transfusion. So does anybody know what this is? The scream? Well, a lot of people think that, but it's actually an anesthesiologist when they come into the room for radical cystectomy. So actually, this was one of our grad students who interrogated 5 million cases within NSQIP and actually looked at the highest risk of blood transfusion. And I think if you'd ask most of us, we'd say cardiac surgery or vascular surgery has the highest risk of blood transfusion. Well, we can be very happy to know that we are number one, with radical cystectomy actually having the highest risk of blood transfusion over any other surgical procedure performed. Also quite interesting, which I was very surprised with, was radical nephrectomy at 27% and large abdominal mass resection. Some of these would be kind of post-chemo RPLNDs, that kind of thing. So I think there is some applicability here to urology, and I would have probably guessed an open radical nephrectomy would have a transfusion rate of 5%. I mean, these would include IVC thrombosis and things like that as well, of course, but that's quite high, and these are large numbers of cases within NSQIP. So blood transfusion should be on the mind of urologists, especially uro-oncologists who perform these procedures. So just to summarize, transfusion is quite common. The risk of transfusion is about 1 in 2 for radical cystectomy. And as I said, there were really no dramatic associations, so you couldn't put patients in sort of risk categories for risk. So does it even matter? So does blood loss matter? I think it probably does. Any surgeon likes to operate in a dry field. I think that I can do better surgery if there is no bleeding going on because you see better. There's cardiovascular effects, no question about that. There's also thromboembolic events. Not just in urology, but across the board, patients who have significant blood loss, even if they don't get a transfusion, are at much higher risk of developing coagulopathies, DVTs, PEs. There's a question about whether there's worse cancer outcomes with higher blood loss. Study after study shows this, but of course there's confounding there. Why did they lose the blood in the first place? Probably they had more advanced disease. But for some things like gender or sex, that doesn't fully explain it, and there does appear to be these associations in observational studies. And of course, risk of transfusion. So do we care about blood transfusion? Is that a big endpoint? Is that something that we should worry about? Well, patients do care about it. Most people don't want to have a blood transfusion if they can avoid it. I think this is quite a conservative estimate of about $1,000 per unit, probably a lot more than that when you think of all the infrastructure that goes into obtaining, screening, filtering, delivering blood products. Acute lung injury is now the #1 risk associated with blood transfusion, but there are immune reactions. There's potential risk of exposure to the things we know about, but also many things that we don't know about. Jakob-Creutzfeldt, other things that are maybe not even screened could become issues as time goes on. Also, independent of blood loss, transfusion is also associated, study after study, with risk of venous thromboembolism. So this idea of coagulopathy that occurs with blood loss and transfusion can cause that. And there have been numerous studies for radical cystectomy showing that those patients who get transfusion have worse cancer outcomes. Now again, there's some mixed, and I would say the better studies that control for a lot of these variables see that that risk is a lot reduced. So this may be this confounding by indication issue again. But there's probably no benefit from an oncologic perspective to getting a transfusion, and there certainly may be some harm even from a cancer perspective, and I'll talk a little bit about that later as well. So I was quite surprised when I kind of dug in a little bit to determine that this was a major issue, and certainly the highest risk among all surgeries that are performed. So what can we do, or can we do anything to reduce it? And I think that we can. And the way that I kind of attack this, and for maybe the residents who are starting a research program, this is sort of the way that I broke down in my mind ways that we may be able to intervene or study interventions. So one is by filling up the tank, so increasing the patient's hemoglobin before surgery. The other one is decreasing blood loss. Less blood you lose, the lower risk of transfusion, I would think. And optimize a transfusion strategy, so being maybe more restrictive with using blood, but that of course would have to be studied to make sure that that's appropriate and safe. So when we looked at increasing in pre-op hemoglobin, there really isn't a lot of data on it. There are in elective orthopedic surgery, there's actually quite a bit of good data showing that EPO and IV iron therapy is actually quite effective in improving anemia. That is something that we are looking at, but there are some logistical issues we found with this. Cystectomy patients are often elderly, they have comorbidities, they're already going through a whole bunch of tests, scans, PET scans, seeing anesthesia, getting stomal marking, having teaching for neobladder function, all these things. So this IV iron therapy is quite, they often have to come in sort of every day for our IV therapy. It's expensive. The EPO is quite expensive. So there may be something to this, but logistically it's going to be hard to actually do in practice, I think, although we are studying this. Decrease in blood loss. So this was where I thought was probably where we could intervene the most, I thought. And I broke down the ways that we may be able to intervene on decreasing blood loss into 6 categories. So surgical technique, surgical approach, surgical instruments, anesthesia techniques, topical medications, and systemic medications. And I will go through each of these and kind of my thoughts when putting together a research platform of where we could get the most bang for our buck, so to speak. So put up your hand if you use careful surgical technique. Only 2 or 3 people. So I say this a little bit joking, but this is where a lot of surgeons actually try to attack. They say, we're going to actually improve how you do surgery. That's a really difficult thing to do. We were talking last night about a study that I'm leading in prostate cancer, and just showing people, you could show someone, hey, your transfusion rate is 75%. They really probably can't change that very much. Most people, I think, are doing their best, and actually improving their individual technique is a tough thing to do. I don't really know how you would even go about doing that. And there are trade-offs. So I know even among the surgeons that trained me and how I work, I'm more of a like packer and move type surgeon, where if there's a little bit of oozing, I'll pack it, move on somewhere else, and keep moving. There's other surgeons at my center who will, spend 10 minutes with 4-0 polysorb trying to sew over a little vein. I don't know what's right. There's trade-offs between OR time, safety, other things. And so sometimes you will accept a little bit of bleeding if it means that you're not injuring, autonomic nerves, things like that. So what about laparoscopy or surgical approach? I thought this would be a actual important thing because of our experience with prostatectomies, where we basically reduced transfusions to 0. I was quite surprised. So this is a systematic review. Still about 25% of robotic and laparoscopic radical cystectomies will get transfusion, which speaks a bit to the idea that a lot of these patients are anemic when they start, and that there is still some blood loss. Are you guys doing robotic cystectomies? Anybody here? Peter? No. So we're not either. I thought this would be the major thing, and if you look at that 25% number, and these again are from surgeons, excellent surgeons at centers of excellence, that would still put robotic cystectomy in the top 10 of surgical procedures for blood transfusion. So I don't think that laparoscopic approach or the pneumoperitoneum is going to solve all of our issues related to blood loss and transfusion. But admittedly, it does reduce the risk of blood loss and transfusion compared to open. So this was instruments. So we use, what do you guys use here? Do you use a ligature device or any kind of thermal device for radical cystectomies? Use staplers? Yeah. Yeah. So ligature staplers. So this was, the Vanderbilt group, Sam Chang, did a couple of randomized trials, which I found quite interesting. So this was, back 15 years ago, they had randomized to stapler versus suturing of pedicles. And they found a substantial reduction in blood loss. Their transfusion rate dropped to 6%, which is really quite incredible. Again, this is before neoadjuvant chemo and things like that. And fewer mean units of blood. Then they did another study, almost identical, with almost the same number of patients, with ligature versus stapler. And they randomized 80 patients, and they found no difference. But what I found really quite interesting with this is if you look at the blood loss in the ligature group, it's identical to what the blood loss was in the control arm in the previous study. And the transfusion rate was what the control arm was in the previous study. So I think there's got to be a bit of Hawthorne effect type thing going on where people felt they were being watched, they were going to be more conservative. So whether or not these instruments actually affect blood loss and transfusion, my personal opinion is I doubt that it is. I mean, I've used all three of these techniques. I think it's faster to use staplers and ligatures. I'm sure you guys would all agree. But whether it actually reduces blood loss in a significant way, I'm not so sure. Right. So it could, although the randomized trials don't really show that. So what about anesthesia techniques? So this is something that maybe you guys have been exposed to in the past or have not on your vascular rotations. So in hepatic surgery, and certainly when we do partial, hepatic resections with IVC thrombectomy cases, we have used this sort of low central venous pressure technique, which has been well established to reduce blood flow in liver surgery. And that's basically where the anesthesiologist through pharmacotherapy reduces their CVP to reduce bleeding. That may be helpful, although there's always a little bit of trepidation when you've got their hemoglobin really low and there's a risk of encountering bleeding. There's acute normovolemic hemodilution. That's also something that's been used in various surgeries. There's actually a randomized trial in open radical prostatectomy that's shown benefit. Essentially what's done is the blood is removed at the beginning of the case, replaced with electrolyte fluid, and then that blood is administered back to the patient after the bleeding has occurred from the surgery. And that can reduce the need for autologous blood transfusion. Then there's cell salvage therapies like Cell Saver. Does anybody use Cell Saver in cancer cases here? You guys use it? So it's an interesting one because it's really not been well studied. There's a... What's that? Yes. Oh, yeah, for sure. Yeah. So we use that for Jehovah's Witnesses as well. But we don't use it routinely. Now, there is some hemofiltration where the blood is kind of put through a filter system before it's transfused back into a patient. Certainly we used it, I remember, in vascular surgery or when we had people on hypothermic arrest. But there really is probably a need for some research in this area to make sure it's safe. And a lot of surgeons who operate on cancer have some concerns about the idea of, picking up blood or fluid and then reintroducing it back into a patient. It might be something that could be done with your group where you could look at some of these circulating tumor cells and things like that that you could get from the filtrate from the Cell Saver. So what about topical materials? So when we did the survey of surgeons, almost everybody used gel foam, Flow Seal, Tis Seal, all of these products that really are expensive and are not all that effective, actually. Does anybody here use those materials in a cystectomy? I know a lot of my colleagues use it. I don't use it very much, but I see almost every partial nephrectomy at our hospital uses Flow Seal. Fairly expensive. Yeah, questionable benefit. Almost all surgeons, academic surgeons in Canada, use these types of products, despite the cost and questionable actual benefit of it. So, brings us to systemic medications, and I think this is actually something I knew nothing about 8 years ago, really nothing about. This is the chemical structure for tranexamic acid, and it's it's a synthetic lysine analog. And how that medication works is it binds or inhibits plasminogen from forming plasmin. From your medical school days, you may remember plasmin breaks down fibrin. So these medications actually are not pro-clot forming. That would be things like factors. If you were giving those, they're extremely expensive. These are actually the reduction and breakdown of clots that have formed in the body. And I think that is an important distinction. There's a really interesting story behind the person who discovered this. So this was post-World War II. Yutako Akamoto was a Japanese scientist who wanted to try and develop a medication to reduce the risk of postpartum hemorrhage. And she did. She identified this drug, that she believed very strongly, based on laboratory evidence, was going to be effective. But because she was a woman, the Japanese medical community would not accept this medication and not accept it as being a drug. So this drug is long off patent. It was written about initially in 1962. She actually lived, so the trial was actually that she wanted to do was done in 2010. And she was 92 years old when that trial started, and she actually kept up to date. She died at the age of 98 2 years ago, and was aware of all of the trials going on with her drug, tranexamic acid. So this was a drug that was discovered and really not used almost at all for well over 30 years. The reason being because she was a woman who had done the research. The drug is extremely cheap, this drug. There are several other drugs like it, but this one seems to have the best balance of benefit and risk. It is one of the WHO essential medicines in the world. Every trauma patient in the city would receive tranexamic acid at the time of the paramedics arriving on the scene. This is standard of care for cardiac and orthopedic surgery across the world. And it's something that I really knew basically nothing about. I remember, writing the Royal College exam, and that would be one of the things that you would have as an option with alum and other things for hemorrhagic cystitis, maybe putting it in the bladder as topical therapy, that sort of thing. I was quite unfamiliar with the use. So we actually did kind of a bunch of work leading up to it, which culminated in a randomized trial. So this is a randomized trial of tranexamic acid versus placebo. So we don't know what they're getting. I think this is going to be,
You're getting the level of evidence from those trials.
Yeah.
What's
the effect?
What were the trial designs and,
Yep.
and effect?
So we have done. I have some other slides here, but we did a bunch of systematic reviews looking at this, like how consistent is the benefit and across what surgeries. So the benefit's about so the relative risks are about 50%. So it reduces the risk of transfusion from 50% essentially across the board. The famous trials that have been done with this medication is CRASH and CRASH-2 studies, which is in trauma, which showed a 50% reduction in transfusion overall. There have been probably 45 orthopedic trials, all of which have shown benefit of about 50%. So our level of precision is getting tighter and tighter and tighter and tighter. I think one of the remaining questions, though, remains in surgical oncology, because none of these trials have looked at cancer patients. We know cancer patients may have unique risks. There was a paper that was published actually from London that had looked at, in an animal model, the effect of lysine analogs on metastases. These were melanoma metastases, and actually showed more rapid growth rate, more metastasis uptake in lungs. The idea was that maybe some of these circulating cancer cells get combined and interact with platelets and thrombus. They are more likely to be able to kind of quote-unquote stick in certain areas, not get degraded, maybe be protective. So there are many oncologists. In fact, we did a recent survey of surgical oncologists in Ontario, and most of them were not comfortable using tranexamic acid in cancer surgery because there's really no trials. Our trial is actually the largest trial that's ever been conducted in cancer surgery. And so there is still a need, I think, to generate evidence, although I feel it's going to be positive for transfusion, and I hope it will be found to be safe and not affect other outcomes that we would like to look at down the road, like oncologic outcomes and things like that. There could also be a bit of a trade-off. Maybe there is an increased risk with drug, but there's also an increased risk with blood loss and transfusion, and maybe they counterbalance. We'll see.
Or you just use it, and they usually don't tell you because they see the case going not as well as they like.
Yep.
After the fact.
So that's a big bone of contention at our center. And in fact, our surgical now I'm a believer in it. I would say good for them. That's smart. I think the evidence is quite strong for it. But many surgeons are not as convinced as I am. And so we need to generate the evidence, hopefully, and maybe I'm wrong. And I'm willing to be wrong, certainly if the trial shows it. But I think it makes sense, in fact. And for other surgeries, now this is anecdote talking, but I do find that there is a visible reduction in sort of how wet the field is. in some major resections, especially retroperitoneal resections, pelvic resections. But there's a lot of controversy around this. There's another trial going on which will probably combine in hepatocellular carcinoma that's being conducted out of Toronto, very similar design to ours. And we just put another CIHR grant in, which we got bridge funding for, to actually do a cluster randomized trial for all high-risk cancer surgery in Canada. So hopefully we can get UBC involved, and we'll see how we're ranked. For the bridge funding, we were the highest ranked grant in the application, so I'm cautiously optimistic that we'll be successful. But I think these kind of data is important because obviously surgeons aren't convinced otherwise, maybe anesthesiologists are. I also think it's a good opportunity to do some nested studies looking at the science behind why some of these outcomes may be effective, and I certainly think your group already has the infrastructure in place to do a lot of these types of studies. I've always thought it'd be very interesting to look at levels of circulating tumor cells or maybe even circulating DNA during these operations, if they're getting the medications or not. Maybe it'll show nothing, but what is the mechanism behind potential changes in cancer outcomes? If this trial is positive and we see that the oncologic outcomes are positive, that would actually be the strongest evidence to suggest that reducing blood loss and transfusion improves cancer outcomes, which we don't know yet.
When are you administering the
Yep, good question. So there's also various ways that it's been administered. When it's given as a reactionary method, so, oh God, I've got some bleeding here, we better give some TXA and go, that's been found to be less effective than when it's given prophylactically. So the protocol that we use is they get 10 milligrams per kilogram loading dose. The half-life is about 3 hours for tranexamic acid, which is the drug that we're using. And then they get a maintenance infusion of 5 milligrams per kilogram per hour. It's been looked at 2 milligrams per kilogram per hour, 1 milligram per kilogram per hour in various different surgeries. It looks like there is not much of a dose effect. So the therapeutic window, I think, is wide, and the toxicity level is very high. So I think you have a lot of anesthesiologists will use like the crash 2, so 1 vial at the beginning of the case and then run another vial in over 8 hours, which is don't have to do it weight-based at all. And in fact, the trial that we just submitted, the larger trial, CIHR trial, has that sort of dosing regimen, so you don't even have to kind of do it weight-based, and that's the rationale behind it. So 1 vial loading dose and 1 vial maintenance is something that you can use in your practice. I think right now would be justified, certainly in anything non-oncologic that you're worried about risk. There's a randomized trial, small randomized trial in percutaneous nephrolithotomy, and you think, nobody gets transfused from that. Well, some do, and there are some other outcomes as well that are important. Visualization during surgery, which has shown a benefit. So I don't do perks, but if I did, I would use it. I don't do TERPs, but if I did, I would use it. And there are a number of trials in TURP. In oncology, I think there's still questions, and that's hopefully what we're going to address with this trial. So we've randomized about 280. We actually have almost all academic centers in Canada contributing. We've got about 285 out of our 354. So this year we'll have finished accrual, and so this time next year I should have an answer for you in terms of the transfusion outcomes anyway.
Is it expensive?
$5 a case, yeah. So it's probably cheaper to your hospital than almost anything it is. I mean, it's off patent, so it's in Canada. It's called cyclocapron, produced by Pfizer. It's $5 a vial. I'm a little bit worried that Pfizer may say, "Hey, the use is going up quite a bit," and start gouging. It's it's pennies essentially in developing countries. It's already started to rise a bit in the United States. It's about $50 a vial now, where it used to be $1. So, but that's an overwhelming problem in the U.S. with their price gouging that's occurring. Yeah, they've actually been accruing very well. I think they have 50 patients in. So interesting you say that. Interesting you say that. So, and I'm not going to talk about any specific site, but when we did our power calculation, we estimated that there would be some, even though that sites we figured were probably around 40 to 60%, we figured people were going to try harder not to transfuse or whatever, and you'd see a drop in our baseline And we had a couple of sites say, hey, our transfusion rate's less than 5%, so do you really want us in the study because you might be underpowered? I said, well, let's do it and see. And in fact, if someone had 5% risk, I want to know what they're doing. I want to go see what they're doing, and we all should be doing it because nobody else in the world can do it. And some of those sites that had less than 5% have 50% transfusion in the trial, and they can't understand why in the trial it's so high because normally it's 5%. But and I think this really, I don't think any of us are immune to this. I mean, I think we all have our bias. I would have never believed that my patients had a 50%. I would have never believed that. But I was wrong, and I think we just don't. Sometimes we don't know. Maybe they're getting a transfusion recovery room, and we just don't know about it. I had a case like that recently of a young woman that got a transfusion recovery. I don't think she needed it. I didn't know about it. It was anesthesia that gave it, and anyhow, it happens. So she was in the trial, and we'll see what happens. So we actually looked in aggregate. So we had done a pilot study first just to see if this was feasible of 100 patients. And interestingly, if you look at the data in aggregate, the transfusion rate was 38%. And if the drug works, goes from 50% to about 25%, which would be the effect that we saw in other randomized trials for other diseases, we would expect the aggregate transfusion level to be exactly to the percentage what we found. Now, I don't know, maybe there's no effect and they're all that way, or maybe this is one group seeing benefit. The other thing is, out of those 100 patients, we had one DVT, and we would have expected 5 or 6 DVTs. And one of the reasons that people are cautious with tranexamic acid or other lysine analogs is, could you actually be increasing those risks? And a lot of people say, I'd rather give 10 units of blood rather than have 1 PE. I don't necessarily agree with that, but regardless, it doesn't seem like it. And most of the trials show reduction in VTE. So I think what we will see, and at least based on those 100 patients, that's a lot less than what we would have expected. We would have expected probably 3 or 4 PEs or DVTs among cystectomy patients, and we haven't seen it yet. So we'll see what the final results show. So bottom line, I think in terms of decreasing blood loss, I think there's probably something to surgical approach. Not as dramatic effect as I thought I would have seen, based on prostate experience, but it probably does help. And I do think that systemic medications, whether it's TXA or other lysine analogs, may be effective. And I'm quite confident that we will see that in our trial. And then the last thing is just optimizing transfusion strategies. And I would say that this is a tough one. This is almost like using careful surgical technique. I think nowadays we are much more aware about reducing transfusions. We only give 1 unit if we have to and see what happens. Where, when I was a resident, someone was anemic, we give them 2 units of blood and, see them in the morning kind of thing. I think that's changed a lot. We're a lot more judicious, I believe, with transfusion rates. There's only one study that's looked at it. This was Sia Dineshiman's study where he had, this is USC. These are highly skilled radical cystectomy surgeons. And he looked at his series compared to before he got there in the USC series, where he used a more restrictive transfusion level. And he was able to reduce the transfusions to less than 40% compared to 94%, which is what the transfusion rate was before he got there. Showing that, it seems practical. All of the cancer outcomes were better, whether that's because Sia is a really awesome surgeon or patient selection or who knows what. So it does seem to be safe. And I think we do this already. I don't see this as an actionable item that would move the needle at all on transfusion rate. From my perspective, I may be wrong, but this is not an area that I have a ton of interest in because I think it's very difficult to deal with this. Sometimes people get transfused during surgery because the anesthesia, the patient started with a hemoglobin of 85. You've got a little bit of, blood loss on the side of the vagina that's, you're having issues controlling, and that anesthesiologist doesn't want to get behind and will give a transfusion. So I don't think, it's not as easily actionable in my opinion. So just to conclude, there is a high risk of blood transfusion. Hopefully, whatever internal biases we have will at least make you question or look at your own patient outcomes in terms of transfusion. Maybe not just for cystectomy, but for other procedures as well. There's really minimal evidence out there on what we can do to improve it, which is what we should be doing, and that's what my research program addresses. I think a strategy is probably needed, maybe not just one thing, but sort of a whole host of things to try and reduce it. And I think that is what is going to substantially reduce transfusion from 50% to maybe 20%, 10%, hopefully maybe even less. And I do believe it's a fertile area of research. I have to say that in Canada, it's really been kind of embraced in terms of collaboration. And I think, seeing the facilities you guys have here, I think there's really exciting potential opportunities to use your expertise and try to help us maybe understand not just the outcome, but what is the mechanism that gets us to those outcomes, and maybe even identify further areas of therapy that might even be safer than what we have currently. So these are my kids on the left. So this was taken last week before I came here. We were sledding on the snow. I'm just kidding, but it's not far off from the truth.
Is that your house on the right?
And that's my place on the right. That's my place on the right. And it's behind. I'm taking it from.
Yeah.
So you guys recognize this place. But Ottawa is if you come in the middle of winter, there's lots to do. If you come in the middle of summer, there's lots to do. You guys have a very beautiful city anyway. Thank you very much for inviting me. It's been a real eye-opener, and really impressed by what you guys are doing here. And thanks for having me.